Good afternoon, everyone, and good afternoon to the moderators. Thank you for inviting me today. I will be repeating part of the previous presentation by Dr. Alessandro, so I hope I don't bore you too much, but I will try to go into more depth. So I'm going to talk about management of headache, but I will focus on approach on diagnosis, and my colleague, Dr. Noof, will focus on the treatment. So diagnosing headache is really important for us as neurologists because of the prevalence of it. So as per the USA data, that the prevalence of a headache is 93% in men and 99% of women would suffer of a headache in their lifetime. So this is a very frequent disease that we will all struggle with at one point in our life. And 91% of people will not function normally when they are having a headache day. So these are two publications that I just thought I wanted to show you. And one of them is from Rashid Hospital, from our department, as well as from the DHA PHC clinic. And we were addressing the diagnosis of headache through our multidisciplinary headache clinic in DHA. The other publication was from Dubai Medical College students, and they looked into migraine in Dubai Medical College student, and the conclusion was that almost 40% of Dubai Medical College were suffering from a migraine. And this brings me to diagnosing headache. So there is the international classification of headache that we are basically using to define and classify the type of headache, and accordingly we proceed in our treatment. So the latest version of it was the 3 beta, and it divided the headache into primary headache. So by primary headache, we mean that it is not attributed to another disease or an associated disease, whether in the CNS or outside the CNS. That is basically primary headache. There is also secondary headache, which is attributed to another disease. And finally, we have other cranial neuropathies that are there, and that might give us also headache. If I go into depth into the primary headache, and this is where I'm not going to go into each and every single entity, but I will cover the most common ones. So migraine is one of the primary headaches, and as you see in this list of primary headache, there is migraine, there is tension type headache, trigeminal autonomic cephalgias, as well as other primary headaches. So we divide primary headache into 4 entities. I hope this is clear in one's mind: migraine, tension type, trigeminal autonomic cephalgias, and others. Migraine is furtherly divided and classified into other classifications. We have migraine without aura, migraine with aura, and migraine with aura is furtherly divided into more types. We have chronic migraine, we have complications of migraine, and other form of migraines. So I don't think this is clear, but I will explain how can we differentiate different forms of migraine, so that when a patient comes to you at your clinic, you can define, is it a migraine or another form of migraine. So migraine without aura, and this is probably the most common type of migraine that we see. To diagnose someone with a migraine without aura, they have to have had at least 5 attacks. They are coming with a history of 5 attacks that fulfill the following criteria. So these attacks have to be longer than 4 hours. So 4 hours and more, up to 72 hours usually. So the duration is one important criteria that has to be in our mind. If someone comes with a 30-minute headache, I don't consider them as migraine. And when we ask about the duration, we need to ask clearly, this duration is excluding getting their PRN medication. So if a patient says, yes, my headache is 1 hour, but this is with the Panadol. No, I need to be very clear in asking them, if you don't take your medication, how long will the headache episode last? And if they say, no, it's usually the whole day or more than 4 hours, then we have fulfilled one important criteria, which is 4 hours and more to diagnose a duration of the migraine. And these patients have to describe 2 out of the following 4. So the location could be unilateral. The character of the headache is either pulsating, throbbing, or hammering. This is what they would describe, a throbbing, a hammering sensation in the head. Unilateral, and the severity is moderate to severe, okay? And the fourth one is that it is precipitated or aggravated by physical exercise. So the patient has to give me 2 out of these 4. If they describe it is unilateral and severe, then that is enough for me. They don't have to have the throbbing character in this case, and they don't have to have the physical aggravation. The third part of the criteria is they have to have either nausea and vomiting and photophobia and phonophobia. So one of these 2 have to be there in the criteria for migraine without aura. So by this, if I have this description, the patient has fulfilled it, I can diagnose, yes, this is a migraine without aura. Now moving to the next type of migraine, which is the migraine with aura. In this case, the patient has to come with 2 episodes, not 5 like the migraine without aura. No, it is 2 is enough for us to diagnose, and they have to fulfill they have to fulfill 2 of these. So the first one is a reversible symptom, which is visual or sensory or speech or motor or brainstem or retina. So one of these symptoms, at least one should be there. So what do I mean by visual symptom? So the patient will come describing that they have flashes of light, scotomas, zigzag lines, spider webs. These are all visual symptoms that might be there. Sensory could be tingling, numbness, or loss of sensation. Speech disorders such as difficulty in articulation or difficulty in comprehending or expressing themselves. And motor such as weakness in one limb or one side of the body. Brainstem symptoms such as vertigo, tinnitus, ataxia, and retinal as in loss of vision, okay? So the patient has to have one of these, at least one, maybe more, but at least one. And the aura of the attack has to build up over 5 minutes, and it should last anywhere between 5 minutes up to 1 hour. So the aura should not continue more than 1 hour. If I see a patient who's coming to describe zigzag lines, usually it will build up over 5 minutes, and it will not last more than 1 hour. So this is one important criteria in the aura itself, up to 1 hour. The auras can happen in succession. So visual followed by numbness, for example. But they will happen usually not together, but one after the other. At least one aura will be unilateral. So the numbness will be taking one side. It will not be bilateral. I'm just giving you an example. And at least one of the auras will be positive symptoms. So by positive, we mean that the visual symptoms is flashes of light, zigzag lines, rather than just the loss of vision. The numbness or tingling are considered positive, while loss of sensation is considered negative. So we have to have also at least positive symptom aura. So if we have those associated aura, then this is diagnosed as a migraine with aura. The next is the subdivision of migraine with aura. So within the migraine with aura, we have typical aura and others, okay? So the typical aura is reversible. So within 60 minutes, the aura will be gone. And it will usually be affecting the sensation, the vision, and the speech. The motor, which is the weakness, the brainstem, and the retina are considered not a typical aura. So those patients that are coming with brainstem symptoms, this is called migraine with brainstem aura. Patients coming with migraine with loss of vision, this is also considered a retinal migraine. While those coming with speech disturbance or sensory symptoms, these are considered migraine with aura, or visual symptoms as well. So the list goes on, and I don't want to dwell in it, but I hope that it's clear in your mind that we have a migraine without aura, we have a migraine with aura, and the aura symptoms are scary symptoms, by the way. If you get a migraine and you feel severe dizziness with it and severe vertigo, you get scared that this could be something more serious than a migraine. If you get a migraine and you have loss of vision for 1 hour, it's a scary symptom. And whenever we see those patients with migraine with aura, we are very careful because we're not sure, is it a pure migraine with aura or is there something cooking? So I'm not going to go into details, but we have more in the migraine with aura as brainstem aura, as the hemiplegic migraine. And I move on into the chronic migraine. So chronic migraine, as Dr. Alessandra has mentioned in the previous lecture, these are patients that are suffering with a migraine for more than 15 days per month for at least 3 months. So for us to say this is a chronic migraine patient, they have to have been having at least 15 days of headaches per month for 3 months, or at least 8 migraine attacks per month. So it's a bit tricky here. 15 headache days or 8 migraine days per month, okay? And we can then diagnose this is actually a patient with chronic migraine, not just simple episodic migraine. The other form of primary headache that is very common, and probably 99% of people will be suffering from it at one point in their life, is the tension type headache. This is the most common kind of headache. And it is defined as well into infrequent episodic tension type, frequent episodic, and chronic types. So some patients will have the infrequent tension type headache, and there's a criteria to diagnose this as well. So the number of episodes that should happen to diagnose it, patients should have 10 attacks per year at least. So that leaves us with once a month maximum of these attacks. These attacks should, the duration should be anywhere between 30 minutes and up to 72 hours, so or 7 days. So it could be a shortly lived headache. It could be a longer hours and days. And the patient has to at least have 2 out of these 4. So the location is bilateral. It's more of a headband in character. It is heaviness, tightness, unlike the migraine. The migraine was throbbing and pulsating, while the tension is just, you feel that the head is heavy. And the intensity is mild to moderate. Unlike the migraine, it was moderate to severe. And in the tension type, it's actually not precipitated by the physical activity in most of the cases. Nausea, vomiting, photo, and phonophobia are not in the diagnostic criteria for tension type, so we don't need them. However, some patients will actually have them at one point during their headache. And this is where there is a thin line between diagnosing tension type and migraine, and sometimes they overlap. We don't need to have nausea, vomiting, and phonophobia to diagnose tension type. They might happen very mild and much milder than in migraine. So again, the frequent episodic tension type migraines, tension type headaches, frequency will be almost 14 days per month, while the chronic tension type, they will be more than 14 attacks per month. That's just some differentiation between the infrequent, frequent, and chronic tension type. The third type of primary headache, which is the trigeminal autonomic cephalgias, and I think a lot of you know about it, and one of the subtypes of it is the cluster headache. So the cluster headache is one of the primary headaches, and again, to diagnose it, the patient has to come and tell me that they had 5 attacks of these. The severity, it's a very severe attack. The patient will describe very severe, usually stabbing pain. And the duration is, again, shortly lived. So it is 15 minutes to 180 minutes. And usually the attack would resolve. It has to have at least one of the following. So at least conjunctival injection, lacrimation, nasal congestion, rhinorrhea, eyelid edema, as well as facial sweating and meiosis and drooping of the eyelid. So at least one of these, the patient has to tell me that the eye starts to tear, they have redness in the eye or drooping, facial sweating, and all of that. The patients during cluster headache, they will give you a very important highlight that whenever they start exercising, the headache improves very much. So they become very restless. Once the headache starts, they start moving around, and some of them will actually describe, I go jogging to relieve my attacks.
Dr. Yasmine, there is 1 more minute for you.
1 more minute, okay. So, okay. Just to give you an idea of the secondary headaches, we have to be very careful, and there are red flags. Whenever we see the first time a patient is suffering from a very severe headache, this is a red flag. Focal neurological sign is a red flag. A headache that increases with cough or straining, it's a red flag, as well as any change in conscious level, in mentality. These are all red flags that this might not be a primary headache. It might be a secondary headache, and if it's a secondary headache, we need to investigate. So there is a list that goes down in the red flags. I think most of you would know about the fever, the neck stiffness, and all that. If you see a patient that is coming with those associated symptoms, please, we need to investigate the patient more. Thank you very much.